Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show. Hey everyone, this is Meidad Goldman, one of your hosts on Living Medicine. These podcasts are brought to you by the Living Medicine Institute, where we run training programs for therapists interested in becoming psychedelic therapists. And we also talk to a lot of physicians and medical personnel who want to get into this field. So we have a guest today who can talk with expertise about that angle on things. So I'm going to introduce today Meidad Goldman. Meidad has a clinic that specializes in ketamine-assisted psychotherapy in Asheville, North Carolina, called Concierge Medicine and Psychiatry. And this was one of the longest running psychedelic clinics in the Southeast, definitely the first in the Asheville area. And so Meidad has a lot of experience working with this specialty. And in this clinic, he's using ketamine specifically with psychedelic trained therapists. And he has become an expert over the years on dosing specifically for this use. So Meidad is also married to me, so we'll see how this goes. We're interviewing each other today. So thanks for coming on, Meidad, and let you say hello, and then I'll just kind of launch into a little bit of things that people interested in the medical side may need to know, as well as therapists may need to know about dosing and medical monitoring.
Sure. Well, thank you for having me. It's a real privilege.
So why don't you first just give the audience a little bit of a sense of what the clinic setup is? Like if I was talking to you from one of the clinic offices, kind of what would you be surrounded by on a typical day?
So our goal in the clinic is to really make our client and patient comfortable. It is very important that the setting, as part of the setting, that the setting will be as such that the client can feel as if they're sitting in their living room. Our clinic is designed for that, where each room, if you can imagine your own living room wherever you are, most of our room have an old fireplace and a recliner and a couch and a little desk, and the therapist is right by their side. So really from the setting is trying to get our client to be as comfortable and to just imagine they're sitting back at home.
Thank you. And I'm going to ask you a little more about the clinic, only because I want to set the scene for what it's like day to day running the medical side of a ketamine practice, leading into me asking you some specific questions people need to know about dosing and other sort of nuts and bolts issues. So can you talk about the staffing that you have and about how many clients you can see with the staff that you have so that people get a sense of the flow?
So currently we have between 5 and 6 treatment room. One of the room can be used as an overflow or a recovery room for our client after treatment, if they need additional time, if they're waiting for a ride. And the flow in the office is typically as such that when the client comes in, we have an appointment every about half an hour. We can run multiple room. We have a nurse. There's another clinician, either a psychiatric nurse practitioner or an MD that works by my side with a nurse. And when the client come, the initial check-in is with me or Dr. Lentini, one of our provider, including set of vital sign, an exam to make sure that the client is ready for today's treatment, that there's no issues that medically needs to be addressed. And then we try to quickly kind of dive in and prepare the client into their journey.
So you have theoretically 4 to 5 sessions maybe going simultaneously at your maximum?
Yes.
Okay.
So
and what kind of...
At max, we will have about 4 concurrent clients at the same time.
And what is the medical staffing needs, in your opinion, to run that many people at once safely?
In our clinic, we have a nurse and 2 clinicians. It's either me and Dr. Lentini or me and Rose, but 2 clinicians with a nurse. And I think that the ratio that you have 1 provider to 2 room is a good ratio. we're probably more staffed than the average clinic out there.
Yeah.
But we decided to do that because we really emphasize and we want the client to feel cared for and to feel supported and to be able to support our client in that manner. And so that's where our ratio is a little bit on the heavier stuff, but I think it's important for the client, and it shows result when the client are really feel at ease that they can drop in to their session very easily.
Yeah, I agree that the amount of medical supervision actually helps the clients relax into that. And just to be clear, when you say clinicians, you're referring to medical staff, so physicians or PAs, in
Yes.
addition to the nurse that are okay.
Yes,
So
that's on top of the
present.
nurse. Yes, on top of the nurse that help us tracking. Each client also have a little ring, like the ring device, that tracks their oxygen saturation, their heart rate, any type of movement, and that is being transmitted via Bluetooth to our personal phones that will alert us if there's anything that we need to be aware of.
And we're specifically talking in this podcast, and this is for the audience, about ketamine-assisted psychotherapy, often referred to as KAP, or the psychedelic work using ketamine. So we're not necessarily discussing our ketamine infusion treatment that you often see in ketamine clinics that are just giving the medicine as a pharmaceutical treatment, which that in itself is a beneficial thing. But just as a reminder, when we're discussing these parameters, it's really about what you feel is useful for KAP or ketamine-assisted psychotherapy. So along those lines, you also have therapists in the room with the client. Just to give the audiences just a visual for what's going on, you have the client is in the room with the therapist, and then the nurse and the doc are kind of going in and out as needed.
Yes, that is correct. So the client has the therapist that is coming before the infusion is even started. The client already have an IV. The client is situated in the recliner. They have their eye mask, their blanket ready. The music is ready. Therapist is right by their side, and the therapist will be with the client throughout the entire infusion and about 15 to 20 minutes beyond the infusion as well, as part of their psychotherapy.
So given that, how often are the medical staff in and out of the room? What do you feel is like the ideal amount? I can imagine it could be too little or sometimes too much.
So we try to, obviously, we get all the physiological data that we need, oxygen saturation, heart rate, any type of movement is being transmitted directly to our phones from the little ring that the client will have. But in general, we are in touch with the therapist and we know each client, and it's really vary between client. Some client actually appreciate if the clinician is kind of in and out a little bit more, because that helped them to feel supported, that helped them with their kind of teamwork, that we're all holding the container that is holding the client. Some client, this interaction, this in and out may interrupt the psychotherapy process. And so we're in touch with the therapist as well as monitoring the drip and the patient at the same time. Obviously, if the therapist can send us a quick note saying, hey, we're talking about a really sensitive topic, kind of stay out over the next 2 minutes, we will try to minimize our interruption, obviously, as long as the patient is safe. So we can monitor them even when we're outside the door and can see exactly what's the physiological parameter, the vital sign for the patient. And we go in and out and checking the drip and adjusting as needed if the drip needs to go faster or slower. But all of those considerations are based on the psychotherapeutic goals that the client and the therapist have together, and they're working together to really customize that drip, not only to each patient individually, but also to the content that come up, to the psychotherapeutic goal, and to the overall work that the client is working with their therapist.
I love that you said that you individualize it, because that's definitely our ethos, this idea that some clients are comfortable with more interruption and some prefer less. And you've also already begun speaking about the individualizing the drip rate. So can you talk a little bit about what you mean by that and what that actually looks like in the clinic on a day-to-day basis?
Yeah, if there is an ideal zone of altered level of consciousness in which we want the patient to be, and we can actually customize and individualize the drip rate to get the client where their ideal altered level of consciousness would be with respect to their psychotherapeutic goal. If the client needs to be a little bit deeper, meaning a little bit more altered with respect to the psychedelic altered level of consciousness zone, it's not just the dose that needs to go up or down. It's actually the drip rate that can play. And because ketamine has a short half-life, we can really adjust the rate. And if we need to go higher on the drip rate to get the client a little bit more sedated or more altered with respect to the psychedelic component of the medicine. And if we need to back up a little bit and the client needs to get a little bit less medicine, we can slow the drip and achieve our goals in that manner.
And so you're describing that adjusting the drip rate is not the same as adding more medicine to their total dose. It's really just how rapidly it's going into their bloodstream. So they perceive it as an increase, but it's
Correct.
more controllable. Is that correct?
Yes, and that is correct. And so if client, we can achieve, if you look at the spectrum of the psychedelic experience from out-of-body experience to out-of-body experience, near-death experience, ego dissolution experience. And obviously it's a spectrum, and we can really get the client to be in the right spot, and that's based on immediate feedback from the therapist who sits with them, that will allow us to really get the client to where they need to be able to handle the process and the content that comes up during the psychotherapy session.
So, in case people are interested in this, what is the communication system that the therapists are using to let the medical staff know, hey, come in or don't come in, or maybe we need an adjustment?
So we let the client know that obviously we're all attached to this electronic leash, so to speak.
You're holding up your phone, though, for those who are just listening. Yeah.
For those who are listening, the electronic leash was referring to my cell phone. And we let the client know that the therapist will communicate with us via text message. And so we are in communication with our therapists that are sitting with our client. And if there's obviously a topic that is sensitive, that the client or the therapist feel that me going into the room might interrupt the flow of the therapy, and as long as there's no immediate need, meaning vital sign or other needs that need to be addressed for the safety of the client, that we can hold back and we can communicate via the text. When we're in the room, we have our own kind of specific sign language that we can, simple sign language, client is doing well, go up on the drip, go down on the drip. We have our own lingo, 1 to 4, 1 to 3, talking about the drip rate of how many drops per minute are being infused to the client.
So you're using hand signals.
Communicate and adjust all of those without any interruption to the client.
By using hand signals.
Right. So we're not talking, there's no talking shop while the client is sitting in the recliner in an altered level of consciousness. And here we are talking about them and about the process, because that will be interrupting and distracting to the client.
And if the client or therapist does want you to come in, how far away are you? How long does that take if they shoot you a text or?
All of our 5 treatment rooms are all on the same floor, and so it's just I'm few meters down the hall. You're talking about 5 to 10 seconds, and we're in the room.
So I think that gives a good sort of visual of the flow and what's happening in the room. How do you choose doses for people? And let's start with initially. Say a client comes in for the ketamine-assisted psychotherapy treatment program, and they have been assigned to a therapist, and when they're first meeting with you, how do you determine the initial dose?
That's a great question. And the first, I will start by saying less is more. I've been saying it all along, and I'm approaching our 8th year since we opened our clinic coming up, and sitting with client over the past 7 years, I would say less is more. There is a finite amount of receptor that needs to be saturated with ketamine to achieve an altered level of consciousness that will allow the client to really have this kind of out-of-body, mild psychedelic, psycholytic, which is psychedelic light, the way I call it, but the psycholytic / psychedelic altered level of consciousness, still out of body, but not all the way to near death or ego dissolution. The typical dose that everyone is talking, the 0.5 milligram per kilogram, really comes from the depression protocol and the studies that were done on that. And I would say it's a good starting dose for a client. I would say that the majority of our client will end up anywhere between 0.6 to 0.9 milligram per kilogram, with less is more. And I will repeat that. And I always give client the example. If you drink a glass or two of wine, you can feel chill, but if you drink the whole bottle, it's not going to make you any better. And that's the same for ketamine or any other psychedelic. And even the MAPS research showed us that the kind of intermediate zone was the most effective. We start at around 0.5 milligram per kilogram. We take into account, has the client has any psychedelic experience? That is important. Obviously, people that had psychedelic experience, that are a little bit more accustomed to altered level of consciousness compared to someone who is completely psychedelic naive, so to speak, that will make a difference. We obviously, those people not based on their actual body weight, but we take into account their ideal body weight. You can have a client that is 300 pounds or someone who is 150 pounds, but we're treating the nuggets, and pretty much they're all about the same size. So considering
nugget, you're referring to their brain.
Considering the fact that we're treating the brain, then ideal body weight rather than actual body weight needs to be taken into consideration. And obviously, each person will metabolize the medicine and will be affected by the medicine differently. Some people are lightweight, so to speak, and some people need the whole six-pack. We will estimate and start somewhere around the 0.5 milligram per kilogram, with a caveat that our first treatment and the experience that the client is having will help us to determine whether or not going up or down is really necessary.
First one is like a dose finding session, usually around the 0.5, and then based on how they do. Okay.
We're entering an era, what is being coined experiential medicine. This is the first time in medicine where we're entering, where we have a drug that not only have a pharmaceutical effect. Most drugs until now, you take a pill and you hope for a pharmaceutical effect. Even with psychoactive medicine like SSRI, benzodiazepine, opioid, you take a pill and you hope for an effect, but the pill itself will not give you any experience. And with ketamine, when you administrate the ketamine, you have an experience. That's the psychedelic element of the medicine, plus potential pharmaceutical, but the experience is really what's going to help us to kind of learn where the patient needs to be, with the point that we're taking the pharmacological effect that we want to harvest as well. And so it's a combination of what evidence-based medicine will tell us, the 0.5 milligram per kilogram, but really titrate to the experiential element and not just the pharmacological element. And on top, we have the psychotherapy. And so we get feedback from the therapist who is sitting there. We check in on the experience that the client have, and we're looking at the pharmacological range where they need to be based on their ideal body weight and other factor that we take into effect, other medication that may interact with ketamine and other physiological state that is important to take into account.
So I know you've been doing this for almost 8 years now, which by the standards of KAP clinics is a long time. I imagine there are things that you started out doing that you learned by experience were not the best, or that you learned some things that to do better over time. So if those who are listening, who are starting from the beginning, maybe can learn from your experience, what are some of the things that you started changing over the span of those years as you were practicing on the ground and seeing what the work was like?
I think the first thing is, as far as the dose, less is more. We all have the urge to help client. And if the client didn't necessarily have the best experience or didn't respond, our initial instinct is to, oh, let's go up on the dose. And I until today, 7 years later, I have to fight that urge and to remember that less is more, because it has proven through the past 7 years. Two, we started providing a specific music track that incorporate binaural beats that can put the client in a certain frequency. Their brain will be in a certain frequency. We typically aim at the alpha range. And I change it because initially you can tell the client, hey, why don't you bring music that you like? But I find out that music, almost like smell, that you can smell the soup and it will take you to your grandmother's house. Certain music, when the client brings that, will have an association that may not be the best for the therapeutic container that we're working. So providing them the music track, have control. Essentially what I'm saying is that have control on the setting. You cannot control the set as in mindset, but the setting is important. The visual that the clinic is set and provided, the music that we're providing to the client, the blankets that we're providing them, the eye mask that we provide, even journals that allow, are all those things are very much contributing and affecting the result of the therapy process that we're working with our client.
Yeah, that's interesting about the music. I'm going to ask you more about that in a little bit, because I think that's just a really one of those topics in psychedelics that has so many opinions. And I think your experience there is really interesting and has been borne out over time by the rest of the staff's observations, including the therapists there. But before we get into music, speaking of controlling the setting, I imagine there's been times when you've had providers in or out of the room that the client doesn't know as well. And I'm just curious what you notice or what difference that makes when the client knows the treatment team better versus when there's someone new or different there.
I think it makes a big difference. I think it makes the big difference because the client, even though we talk from the beginning that every ketamine session is going to be different, almost like lucid dreaming, you never have two of the same dream. You never have two of the same ketamine experience, so to speak. It's going to be different. But having a provider and a familiar face that they're familiar and used to, someone that they can trust, someone that they have interacted in the past, we build rapport. We know their entire support system. I know who brought them, who's going to pick them up, family, we can talk. And almost as a physician, I think it's parallel to any other client that I see, either in the emergency room or in a house call or in the clinic. If you do build this rapport with the client, it makes a big difference and allow the client to really be at ease from the minute they walk into our office.
So back a little with the subject of music, you're using a sort of subtle, you said alpha wave binaural beat track that it sounds like most of the therapists have in the clinic have sort of become accustomed to and work with, or do some therapists or patients like to use their own music? And just what are your thoughts on that?
Most of the therapists in our clinic will use our track that we have with the years. We started our clinic in 2017, and initially there was a lot of experimentation with the music, where the client brings their own music, or the client select with me or the other clinician what type of music. And later we kind of gravitate toward a specific track that is really in the background, and it does not direct the client. I always consider the music is almost like flying carpet. It just allows the client to kind of float. And if they need to fall back on that carpet, on that music, to re-anchor their thought process and then venture into a specific thought or feeling, that it works. Some therapists in our clinic do bring their own music, but again, this is music that they have kind of curated or selected specifically for that client. And so overall, I would say have the clinician control the setting and bring the specific music rather than the client bringing their own music. Typically, it has some association that may not necessarily be the best. Obviously, there is exception to all of that. And as far as the music type, background music, we no words in our selection, and that really kind of is not pushing the client and directing the client to have a specific experience, but something a little bit more neutral.
Yeah.
That will allow them to just kind of rest on the music and flow with it versus being directed by the music.
Especially because the therapists are really having a conversation over the music. And that conversation is a psychotherapy interaction.
Yes.
That makes sense that you don't want the music or the tone, the emotion of the music to go run counter to what's happening in the therapy session. So I think that makes a lot of sense. And I know that we've all kind of gotten on board with that over time as working better in our clinic over the past 8 years. Yeah. So I know that you run a consulting business and you have taught, trained, and mentored a lot of physicians or medical providers that want to do the exact same thing you do, run a KAP clinic. Everything from how to find a site and how to set up your legal entity and run the administrative aspect of the practice, how to obtain ketamine in the right ways and how to dose it for the different routes, how to run things on the ground, how to schedule, and so on. So I know that you're a wealth of information and already do a lot of mentoring in this. In case, I'll also put that information along with this podcast so people can reach you for that. But I want to ask you a few more specifics that might help just the general audience who's listening in take some pointers for how they're setting up their own clinics. So one is, I know your appointment times are 2 hours long. I'm
Yes.
curious kind of the flow of how that time increment was chosen and what the flow of that looks like as far as what happens when the IV drip starts and stops, and walk me through that 2 hours.
So in our clinic, we start at 9 in the morning, and we're in the clinic until 5 in the afternoon. But I will take the example. I mean, some patient will start at 9 or 10 or 11, but let's take the 9 o'clock patient as an example. The appointment time of 2 hours, I think it's important. And I know that most clinics are not necessarily that generous with their time, but I feel that, again, this is important because you want to allow the client an ample amount of time to not only benefit from the psychotherapy with their therapist, but will have an adequate time to drop in and to exit with this mini integration that the therapist and our clinician are doing. So the 9 o'clock patient arrive to the clinic, they will take into their private room. The nurse will go in with them, with one of us, one of the clinician typically, and check in with the patient. First of all, from a medical point of view, has there any change in medication? Has there any change to their physical state that we need to know that may affect and then dropping into the psychological, emotional realm of entering this, I can call it a sacred space of their journey that they're about to have. And the check-in is around 15 minutes from 9 and 9:15, where we will check their vital sign, make sure that the client is ready physically, emotionally, and mentally to enter their journey, and place an IV. And by 9:15, 9:20 at the latest, the client is ready in a supine position on the recliner with their blanket and the eye mask for the drip to start. The drip itself will go for about 45 to 50 minutes. And so if we start at 9:20, for example, we will go until 10 past 10, in which the patient are still going to feel the medicine and altered even after the bag is empty and all the medicine is in. They will still feel the effect of the medicine for another about 15 minutes, maybe even 20, but around 15. So if we start at 9:20, the bag will run until 10:10. The client will still feel the effect of the medicine until 10:30. At that point, at 10:30 until 11, the therapist can still have some time to do a mini integration and works on the things, the immediate things that needs to be addressed, while the patient is kind of back into their normal level of consciousness. And by 9:40 or so, we will come into the room after checking in with the therapist that it's a good time for us to enter, to get the IV out, to assess the patient physically, medically, that the patient is feeling okay, that their session went okay, both physically, emotionally, mentally. And around 10:50 or so, the client will be ready to leave the room. So around almost 2 hours. And obviously we have, those 10 minutes buffer if they need an additional time and need to talk to the therapist. We have a recovery room in our clinic that if the client is being picked up or they need some more additional time, they can go into the recovery room, which is a private room where we can provide them a little snack, something to drink, keep checking on them, obviously, while they're over there. But that's pretty much the time between 9 and 10:50 to 11, where the client is ready to depart and being picked up by either family member, loved one, or whatever means of transportation. And obviously, if they need extra time in the clinic, we have the space for that.
So I don't want to spend a lot of time today on other medications because I think people can approach you individually, and you've done other work publicly talking about this. But I know that your philosophy is not to provide other medications in the IV with the ketamine, just ketamine, but you do provide as needed medications for things like blood pressure or nausea. But I believe in the clinic, it's pretty minimal because of the thorough medical screening that people have ahead of time.
And
the thoughts that you just want to put out as the most important things without, necessarily going into all of your policies, but things that you just think people need to be aware of there.
So we do have nausea medication. We can provide it both IV or sublingual dissolving tabs. Zofran is most commonly used. I can tell anyone who experienced nausea in other clinics, if you dose people correctly, the number of people who needs any type of nausea medication, I can count on one hand the past 3 years of client that needed nausea medication, and many times it's not it may not be even the medication, it could be the content and the emotional things that they're dealing that contribute. But we do have medication. We have medication for blood pressure if their blood pressure is high because of their emotional state or not control. We will be able to provide them. And obviously we have as a backup, and so far, knock on wood, we never needed to even use them, but we do have benzodiazepine available in the clinic and all of the other medication that we need as a clinic for resuscitation. But again, knock on wood, in the past almost 8 years, we have never used them.
I want to circle back to the thing that you said was your main learning opportunity. And also it's the same thing that I think you have said before, that you feel like a lot of other clinics make the mistake of, which is the dosing. And you've also named that there's a lot of kind of push from clients or other providers, or sometimes even from yourself, to go up, and you've learned to resist doing that. And I know we've discussed in the past, when we have patients coming in from other clinics, that they often have a history of being dosed way too high to do effective KAP work.
And the client will tell you, they will telling you, oh yeah, and they needed to give me medication. They need to give me like Ativan or some other benzodiazepine, or they need to give me Zofran because every time I'm getting nauseous. And when you ask them about the recall from their session, they can't really even be sure exactly what happened. And so,
yeah, I mean, just to put it colloquially, they need to be able to talk to their therapist and have a conversation. And
yeah, I like my patient to be what I call in the 30 to 40,000 feet view, where they are up here and having a direct view of their life, but able to interact and able to see things. But if you give too much, you push them to the stratosphere and beyond, to beyond the atmosphere, and then you essentially, it's a return to your investment, diminished result. And I see that over and over again, where clients are being dosed too high, their therapy process is being affected.
So let's just talk then briefly before we end about what we think might be the most useful take-home point for some people looking to have your job and do what you're doing. And that is on this subject. How do you and the therapists deal with situations, which I know are common, where the client will say they think they need more medicine or they don't feel it enough?
So first, I would say that, everything that we learned in medical school or in residency, really none of those things is prepare us to the work that you're doing in the ketamine clinic. I mean, having client going through altered level of consciousness and a psychedelic trip and talking about things that are not, they're not in a day-to-day ring. Most some people will call them in the woo, things that is not something that you have been prepared for. And so being open to that as a Western allopathic medicine educated physician, and being open to other things that we may not be able to explain on the day-to-day is very important to allow yourself. And in terms of, I deviated from your question, but the day-to-day is to just keep in mind each client individually and try to get them to where they need to be.
So if you are called into the room by a therapist or who says the client is asking for more medicine, or they think nothing's happening, are there techniques that you or the therapist use to sort of work with that lower dose? Because I know that another option is going up on the dose. And also you have learned over time that it kind of works better not to do that most of the time. So I think there's a lot.
First, you don't need to go up on the dose. We can just increase the drip rate and allow the client to drop in a little bit more if needed. But in addition to maybe increasing the drip rate, something is happening to the client. And often they either resistant because of whatever they've been working on, or the things that they're coming into the treatment, they would not let go. They have to be in control. They're not at ease and they're not relaxed. And so often when you see the client saying, I don't feel anything, nothing is happening, it's typically because they're not ready to kind of drop in the session. And
by drop in, you mean sort of relax or let it take over?
Relax and allowing the medicine to kind of guide them into where they need to be. The other aspect is that what I see in ketamine is that the things that we suppress on a daily basis are kind of going to come up during the ketamine session. All your things that you have suppressed in your subconscious or unconscious are going to come up. And many times the client is having kind of a hard time with those thoughts and feeling, and they will try to resist them and try to block them. And that's where necessarily the therapist and us is trying to work with the client to allowing them to drop in more and to see what is it that they do feel and what is it that they do think and feel, both physically and mentally, during that time. And
So a lot
often,
of this is the techniques the therapists are using to
yes,
coach the person to work with what's already happening, and rather than assuming they need to be at a stronger dose.
correct. And the answer is not necessarily going up on the dose. There's other technique that can help the client experience to be shaped without necessarily just increasing the dose, but
Yeah.
allowing them.
So I'll just put a plug here for LMI's therapy training programs. We actually teach therapists these very skills. So I know you're on the medical and prescriber side, but I just wanted to get, to hear you speak to what that looked like from your end. Before we close, how about just a more fun question? Like, what is sort of the strangest part of your job? Like when people meet you and they say, "You do what?" I mean, what are some things that surprise you or they just find interesting or that you didn't expect?
Working with client and allowing them to drop into a different phase of life. Well, they're still aware that they're in the clinic on the recliner talking to me, and yet they could meet a deceased loved one who is no longer with us and have a meaningful interaction and conversation, or meeting their young version or an older version of self. And how is that come apart? And talking to client as they're getting ready for their journey and as they emerge of their journey has really opened my eyes to the things that are not being taught in medical school, and really be open that anything and everything is possible, and really allow the client to drop in without any preconceived notion, without any judgment, without any type of criticism, but really allowing them to go wherever the psyche needs to take them. I think the psyche knows kind of where they need to take someone, and it's really beautiful to see that happening as you work with a client from start to finish.
So, any last words of advice for medical providers who may be where you were 8 years ago, wanting to get into this work and sort of not sure where to start before we close?
Um, hmm. Well, first of all, first and foremost, it's still all about the patient. So doing the right thing for the patient is the number one things that go in front of me, in front of my eyes every single day. It's a real privilege and an honor to participate in someone's journey, and then to really allow yourself to decide if you want to devote yourself to a ketamine clinic, is to understand that administrating the medicine is only one small part, but holding the space and holding that container is the bigger part of the job, and be ready for that. If this part of the job is not your cup of tea, then running a ketamine clinic may not necessarily be the best route for you.
That's a great answer. Especially someone coming out of emergency medicine in a busy ER, you would know, right? It's a very,
Yes,
very different energy.
it's a different energy. It's a different energy. It's still an honor, but it's a different energy and a different vibe. Yes, medical knowledge is very important, but it's beyond the medical. And I think that become evident over the last 7, almost 8 years, and have made me a better clinician.
Well, thank you so much for doing this today. We'll add the information to this podcast in video form about how people can reach you for mentoring or career counseling. And you also do trainings where people travel and shadow you in the clinic, as well as a lot of that over Zoom. So we'll put that information and put it out available. You can also find that on Living Medicine's website at livingmedicineinstitute.com. So thank you for coming. It was fun to interview you, and we'll close and have you back on in the future.
Thank you for having me.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.